Alrighty, let's go ahead and get started. Hi, everyone. Thanks for joining this month's Washington Healthcare Facilities Community of Practice webinar. We're really excited to hear from Josh and more about the NYs, and I'll kind of introduce him in just a second. But first up, some quick announcements. We're planning a few upcoming webinars. Um, we have another WashFit systematic review webinar that we'll be presenting on, some updates on evidence maps for Washington environmental health and healthcare facilities. We have some other topics we're working on around healthcare waste management, cleaning, and Washington healthcare facilities in fragile contexts. We'd love to hear from you all. If you have other topics you'd like to see featured in an upcoming COP webinar, please feel free to drop those in the chat, or you can send me an email and I'll drop my email in the chat as well if you have some suggestions for topics you'd like to see. We may also send around a brief survey to kind of get your feedback as well. We also wanted to offer to everyone, if you have a feature project on Washington healthcare facilities that you'd like featured in the Global Community Practice newsletter that is we co-host with WHO. The way this works is we like to highlight a specific project or success story among of our members and any other organizations that are working in Washington healthcare facilities. So if you would like to participate in that, or you have something you'd like to share, please email Darcy Anderson with your ideas, and she can follow up with you on sort of the logistics and what goes into preparing one of those. If you aren't aware, these webinars do get recorded. So if you've missed previous webinars, they are all available on the Washington HCF YouTube channel. We've had some really great ones. The WashFit report was launched last month. You can watch that video. There was a really fantastic study on water quality in healthcare facilities from Dr. Leanne Ong from University of Oxford. And Rick Johnson presented the JMP update report that was launched last year, and even about 5 months ago, the Global Framework for Action. So lots of great content. If you missed it, please be sure to check out the YouTube channel. I will also drop that link in the chat once I stop screen sharing. So our agenda for today, we will hear from Josh Miller. Josh, if you don't know him, has worked extensively in the WISE scales work at Northwestern with Dr. Sarah Young. And if you're not aware of what WISE is, it's a cross-culturally validated tool to measure experiential water insecurity. He recently, or sorry, I guess in 2020, not recently, joined UNC as a doctoral student in nutrition, and he looks at the links between water insecurity and food insecurity. So in his copious spare time, he has lots of other projects, which includes the NY scale, the Institutional Wash Insecurities Experiences Project. So he'll be presenting today on some of that work and updates. Some of you may have seen some of this content at Water and Health, but I think Josh has a lot of exciting updates. I will turn it over to Josh. And if you have questions, please feel free to drop those in the chat. And then once we get to the Q&A section, you can also feel free to unmute and ask Josh questions. So with that, I will stop sharing and turn it over to Josh. Josh, feel free to take it away.
Right. Here's always the scary part, technology. Hi everyone. Okay, let's see. Ryan or anybody, how's that looking? Is that full screen
Looks great.
normal?
Yep,
Okay,
perfect.
sweet.
Thanks.
Well, thank you everybody for letting me join. I have shared this with Ryan and Darcy and other folks before that I am relatively new to the space of healthcare facilities and institutional wash. So I have a lot to learn. So I also appreciate the opportunity to talk at the end of this and learn about how to make this tool and project better. But to just start off, I also just want to share that this is a project of many people and it's an ever-growing team, and this is only a small number of people who are out doing the work for this. So I just want to start by thanking all of these folks, and some of them are on the call for helping to support this work. And if you're interested, I'll flash this up again later, but there's opportunities to join this project. It's very much in progress. And so maybe you're wondering, what is the project? Why would I want to join this? So as Ryan said, this is the project is called the Institutional Water, Sanitation, and Hygiene and Security Experiences Project. And we're trying to understand and measure users' experiences with wash services in both schools and healthcare facilities. So I'll start just really broadly of why we are doing this project and why measurement matters. I know that that's of interest to a lot of folks attending. So of course, we all know that reliable and sufficient access to wash services is fundamental to human health and well-being. It's central to providing good care and everyday practices at the household level. Um, and how we measure and think about wash services not only informs how we think about gaps in service and the state of wash globally, but it also helps inform how we plan to try to advance progress towards universal access to these critical services. So I'm going to take a step back and deviate a little bit from healthcare facilities to just share the impetus for us doing this at the household level and how that inspired us to eventually move into healthcare facilities. So this is a picture of a water source that some of my research is done on the Galapagos Islands. This is the way a lot of folks on the island get water. There's a piped water system coming in from the municipality. People then store it in these large tanks, and then there's a pipe going into the household. So it's a piped source on premises. And I also, when I was doing my work on the island, I measured the water quality at all these sites. And all of the water that's being delivered is free from coliform bacteria. So based on JMP criteria, this is a safely managed drinking water source, which is great. That's really helpful information. But when I was doing interviews with people, it became pretty apparent that there was a lot of water issues that weren't being captured with this metric. So for instance, this is a quote from the same user and owner of this water source, describing that in this past month, I've had to order a water tanker and it's like going back 17 years because the water from the tanker arrives dirty. So the person was sharing that there's a lot of variability in the water source and given seasonal fluctuations in rainfall. And there's further on in this interview, the person also just said that they didn't trust the water that came from the municipality, so that they didn't use it, even though, as I had mentioned, it was free from coliform bacteria. So there's still a lot of distrust of the water source. And so that had implications for the health and well-being. And we would like to try to somehow capture that and measure that. So in 2017, some folks and I uh, sought to develop a cross-culturally validated tool for measuring water insecurity that centered people's lived experiences and helped to get these other dimensions of water service. So what that looked like was pulling together a bunch of candidate items and then implementing those in a bunch of sites globally. This was about 8,000 households across 28 sites in 23 different countries. And I'll save you the boring statistics and just say what came out of it was a validated 12-item tool. So what this looks like in practice is you would take this 12-item survey, go to a household and ask somebody these 12 questions. And, they take the form of something like in the last 4 weeks, how often did you worry that you would not have enough water for all your household needs? So that would be considered maybe a less severe experience all the way down through going to sleep thirsty because you didn't have enough water or having no drinkable or usable water whatsoever. So this is a slight shift in how we traditionally measure WASH, but provides complementary insights into how folks are using and benefiting from WASH services that may be available on premises. So the scales, these were developed and launched in about 2018, 2019, and they've really taken off, which is exciting to see. And they have now been used in quite a few sites globally. So there's both a household measure and an individual level measure. And it's been used in implemented in the Gallup World Poll, so we have nationally representative data from quite a few countries, more forthcoming in this calendar year. And a lot of different organizations have taken it up, which is maybe the most exciting part, that it has utility for monitoring and evaluation efforts, and it's not just a purely academic purpose. Uh, so to give a sense of what this tool can do, and again, JMP can also do this, but now this is getting down at the individual household level. So now we can start looking at things like gender disaggregated experiences of water insecurity. This is a really crude way of looking at it, but basically this is looking at on the x-axis is the mean score, water insecurity score among women, and on the y-axis, it's for men within the same country or region, and just plotting them to see if they were perfectly equal, that would be along the dotted line. So anything below that is more women are reporting water insecurity, above that is more men. So we can see that across countries and within countries, there's differences in how many people are reporting insecurity. The tool ranges from 0 all the way up to 36. Anything above a 12 on the scale is typically considered moderate to high water insecurity. So again, this is just one way of starting to look and see, okay, in Cameroon, it looks like maybe more women are reporting water insecurity, whereas it's a little bit equal in some of these other countries. Can also start to look at things like household income in relation to water insecurity. So no surprise here. This is a similar analysis, but typically poorer households are more likely to have greater water insecurity relative to wealthier households. But like I said, this isn't just about mapping and understanding who doesn't have access, but helps to inform interventions. So this is a quote from Charity Water, who has been a really great supporter of this project and has now included the WISE scales as part of a key performance indicator in most of their projects. And I'm going to just highlight one example of how this was useful. So this was a project in Nepal where they were trying to improve water access, and it was a multi-level intervention that included both building infrastructure, but also improving governance and management of the water sources. So it went from these water sources where folks had about a mean travel time of 25 minutes to providing services that were much closer to households and were coming from a source that was of better quality. And so just to give you a sense, this is among like 100 individuals. With the JMP criteria, we can see that the project had impact. So at baseline, about 40% of folks had a limited water service. And then by end line, 100% of the households in the project had an at least basic water source. Okay, so that's really helpful information. But we it doesn't quite get at the human impacts of that. So, which is sometimes more helpful for getting donor dollars and understanding the health and well-being impacts of these really important wash infrastructure improvements. So, for instance, we can see that worrying about not having enough water dropped from 70% down to 15% after the intervention. And what was also useful with this tool is that we could see that there were still people reporting some experiences of water insecurity. So Helvitas and Charity Water are using this information to help inform other areas that could be targeted in future interventions and to help understand the full scope of the intervention. And so, for instance, we can see that about a quarter of people still were reporting difficulties washing clothes due to water problems. So that's helpful information to try to dig in and understand why that is, even though everybody has a basic water source. But like I said, I will come back to healthcare facilities and schools. WASH is important beyond just the household settings. In 2019, I thought we were done with scale development and we were going to be able to just move ahead with this tool. But John Brogan, who some of you may know, really great guy at Helvitas, and he had shared with us this tool is really helpful for our projects among household settings, but we also work in schools and healthcare facilities. So is there any way we can adapt these experiential tools to try to capture those experiences in those settings? So that happened in about 2021, 2022. And it just was so obvious that we need to also move into this space. So, as I said, WASH in institutions is really critical for health and well-being. So for schools, it's important for school attendance and performance, and both in healthcare facilities and uh, schools, it's important for reducing the risk of infectious disease and improving health outcomes and reducing the risk of hospital-acquired infections. Also important for staff, student, patient satisfaction. So the likelihood that people will continue to use these services and has implications for the sustainability and cost of services. So are people likely to attend your facility, or are they going to forego care because they don't think it's a safe environment and it would be better to go to a different facility or just not seek care at all? And finally, we just know that there's a human rights aspect to this. It's about human dignity and safety to have reliable access to wash at all times in all settings. So similar to the household sphere, there is a pretty comparable situation. It makes sense that we would start by measuring what we can see. So that's currently how we typically track progress towards WASH in healthcare facilities and schools. So this is from the JMP report and their service ladder for uh, progress towards WASH in healthcare facilities. So we can see that the highest level, the basic service level, is mostly looking at supply side indicators. And what I mean by that is looking at the facilities that are available and the functionality and the state of those. So for instance, at this institution, we can see if you were to look into these facilities, you would see that it's an improved sanitation facility. They have locks, they're gender disaggregated. But what we don't know is that whether individuals feel safe accessing it. Do people consider this an adequate source? And is it actually used, or do people try to avoid it because they don't think it's of sufficient quality? And this has been borne out in quite a few qualitative papers. This is one that I'm highlighting that came out this past year that I found to be really informative and help reflect why the lived experience matters and why these supply side indicators are useful, but don't always capture the full picture. So, this one female student was sharing that the toilets, although improved, were not considered safe and clean, that there was still quite a bit of work that had to be done to bring water to the sanitation facility to use it. And this end quote that I was highlighting says, I hardly use the toilets even on normal days due to the smell of the toilets. So again, people adapting and changing and not using these services that people probably invested a lot of resources and time into trying to build up and get to the point of user satisfaction. So the point of this InWise project is to try to develop complementary tools that can help provide additional insights into the whole experience of not just whether the service is available, but whether it's adequate and used. And we are hopeful that these tools, as I said, they're a work in progress, will help to provide another insight into the magnitude of of issues in institutions, and also because they're being targeted at the individual level, so staff at healthcare facilities, patients, students, that we can start to disaggregate and look at different experiences within institutions. So among men, women, among younger and older people, folks with disabilities or not. And then also, again, as was seen with the household version, hopefully this can also help with monitoring and evaluation efforts, help inform the development of more effective interventions, and finally, to help demonstrate the value of improving WASH. So that quote from Charity Water sticks with me quite a bit, where they have said that this has helped them garner more funds and donor interest in their projects because attaching the human voice to these projects tends to move hearts and minds a little bit more. So it's great to show that previously there was no piped water system at a healthcare facility and now there is, but pairing that with data that shows that people are worrying less, trust the service more, um, feel more supported tends to yeah, have sometimes a little bit more resonance or impact. So how are we doing that? There's three main phases of scale development. The first is literature review. So and defining the construct that you're trying to measure. So I'm not 100% sold on the term wash security for this application, but that's kind of what we're working with right now. And what we mean by that is we're thinking about water, sanitation, hand and bodily hygiene, menstrual health and hygiene, environmental cleaning, so the safety of services within the facility, and then how is waste being managed and disposed of. So this is holistically kind of where we're thinking and looking. Potentially addressing a question that might come up is we are not considering currently electricity, um, although that is a really important aspect of healthcare facilities and their management. We are really squarely focused currently on WASH. Some of the questions we've developed are would capture if there is energy issues, but wouldn't be the most direct way of asking that. So it's WASH currently, but maybe in the future something with around electricity and energy supply. So once we kind of define the scope of our what we would like to measure, what's the construct we want to measure, we've then gone through and there's been dozens and dozens of ways of purported ways, best practices for measuring wash in institutions. So we've tried to aggregate as many as we can find within the published literature. And so, for instance, you can see this one. This is a screenshot from an Excel spreadsheet of kind of what we're doing. So we will look at all of those different tools, and then we look at the items and the survey questions that are being asked and what they're trying to measure, and then we map out what explicitly is being measured. So, for instance, this Center for Disease Control within the U.S. has this WASH toolkit that they recommend for using internationally for measuring the state of WASH in healthcare facilities. There's many more questions than what I've shown here, but basically we were trying to first assess what domain does it fall into? Is this primarily a question about water, sanitation, hygiene, waste management, or environmental cleaning? And then with those same items, we mapped what aspect of wash were they measuring. So thinking about that diagram I had earlier, are we looking at trying to capture availability of the service, the accessibility of it for different users, the perceived quality or the objective quality of the source? Is it an acceptable source by users and is it considered sufficient for different needs? So not just does it supply water, but is it enough water for surgeries, for hand washing, for drinking? Um, so once we had done that, we then developed a set of candidate items based on that to try to understand how are people conceptualizing and currently measuring WASH in healthcare facilities and schools. And in 2023, we sent out a survey to a bunch of different experts in the field. So these were both practitioners, different folks within NGOs, engineers, folks at WHO and UNICEF, and asked them to rate some of these questions. So these are some candidate items that would potentially be asked to the staff of healthcare facilities, ranging from perceived water quality to thinking that the insufficient water might pose a risk to either their health or the health of patients served by the facility. And essentially, we asked each individual who we contacted to provide feedback on each individual item, saying whether they think they should keep the question as is, revise it, or just drop it because it's not measuring the construct well. And so we took all of those data and came up with a refined list of questions. We have different surveys for within schools. There's a survey for students and another one for staff. And then within healthcare facilities, we have two different surveys, one for staff and one for patients. And we are currently at phase 2 of the project. And what that looks like is implementing these items that we've had vetted by some experts and implementing them in a bunch of different sites globally. And thus far, this is early days. We have received and completed data from some schools in Ethiopia, schools in Uganda, and healthcare facilities in Uganda. And we have a lot of upcoming work. So there's a lot of sites that are just now starting data collection this week even, and a lot more in the coming months. So there's about to be a whole avalanche of data. Um, but as you can see, we have quite a focus right now on Sub-Saharan Africa, and there's there will be a pitch later to hopefully recruit folks who are working in other settings as well, for this to be a truly cross-culturally representative survey. So what are folks doing within these sites? We're asking them to sample a diversity. We're trying to sample a diversity of contexts and a diversity of institutions within each of those contexts. So uh, the way this study is designed is not intended to be representative of a particular area, but it's meant to capture the heterogeneity of facility types and service conditions that could impact users' experiences. So it's as a way basically to stress test these items. Does it perform similarly in rural and urban areas? Does it perform in areas that are currently in a rainy season or in the dry season? So we're trying to stress test these items by getting all this diversity. And then within each of those sites, we're asking folks are implementing a small number of cognitive interviews with respondents. So that's going through the questions and just asking them, when you hear this question, what do you think of? How would you answer it? This is a great way for us to know whether the questions aren't working well, whether they need to be changed, or retranslated. Then we implement the surveys, and we also do the traditional school observation assessments. So we're asking folks about their experiences, but then also comparing that to the JMP criteria and a few additional questions that we've found useful from that literature review we conducted. And in terms of sample size, cognitive interviews are, at one to two dozen people. And for the full surveys, we're looking at around 300 to 300-ish folks within the different types of groups we're looking at. Uh, so the data we're collecting is both users' experiences, but also some of their background characteristics and their overall satisfaction with WASH services. So the satisfaction with WASH services and some of these other uh, markers of WASH adequacy we'll use to validate the tool. So we'll look at the experiences and compare it against what's the functional service, what's users' reported satisfaction with the service. And then looking ahead, we're starting data analysis now, but data collection and analysis will go through 2026 with hopefully a finalized tool out and ready for full deployment and uptake in 2026. Okay, so that was a lot of the logistics, and I'm going to spend a few minutes now talking about what we've actually found. And I'm going to ask for some slight forgiveness. I had pitched this to Ryan of we have data from healthcare facilities. It is still in the midst of being analyzed from Uganda. So I'm going to borrow some slides from Marissa Bowler, who works at AAVOG, and she presented this at UNC Water and Health this past year. I've updated the slides slightly, but this is from schools, although they are also doing this project in healthcare facilities, but those data just came in hand and I wouldn't feel comfortable sharing them quite yet. But to give a sense of how they were able to become part of this project, so they were already doing a partnership between between AAVOG and Makerere University in Uganda. And it is this, again, similar to Helvitas, an integrated, inclusive approach to trying to improve WASH services in towns, specifically these two sub-municipalities, these two districts highlighted here. And so the way they're doing that is doing an assessment of WASH and solid waste management in both schools and healthcare facilities. Like I said, we have data for schools right now and healthcare facilities forthcoming, but I would be happy to share those with people if they email me in like maybe 1 or 2 more weeks once we get them all analyzed and cleaned. But to just walk you through like what this looked like for them. So they selected 10 schools, 5 within each of these different districts. And they, again, were trying to sample and maximize heterogeneity in terms of both urbanicity, types of schools that were being sampled, so both primary and secondary, the size of the school facilities in both public and private. And this is analogous to what we're trying to do with the healthcare facilities in Uganda. So looking at both public and private healthcare facilities, those that are a lower level, and then those that are maybe larger serving institutions, so ones that just provide outpatient care to those that also provide inpatient care. They conducted cognitive interviews with folks about these 5 different domains to try to understand how they are using these services and if the questions we're developing work well. And then based on that feedback, we adapted the surveys slightly. So most questions were well understood by students and staff, and they were also well understood by patients and staff in healthcare facilities. But there were certain items, a few items that had been flagged of needing to be changed or updated. So for instance, this question about schools this was directed at staff. Uh, the phrase "how often" was slightly confusing to folks, so we had changed it to "how many times." That was easier for folks to grasp. And then also, you can see this was pretty wordy, and there were a lot of different concepts we were getting at here. So the original question had asked about alterations, disruptions, or cancellations. We've changed that now into just were school activities impacted by water problems. And there was also some redundancy in questions, and we had found that people were thinking about the items similarly. So, for instance, there was this question for staff in healthcare facilities of how often did you worry that problems with water would pose a risk to, there was one question about to the health and safety of patients, and then a different question about to your personal health and safety. And most people were saying, I kind of think about those similarly. How I feel about how it would impact patients is also the concerns that I would have for myself. So we've combined it to a question about how do you think water problems might impact your personal safety and that of patients as well. So once they got these data and the surveys were refined, we've implemented this among students. There's about 600 students sampled and 160 staff across these 10 school facilities and comparable sample sizes for the healthcare facilities. So what's the value add? What have we started to learn from this project? So I'm going to zoom in on one school. Looking at just within this school, we had sampled 110 students and we interviewed 29 staff. It's a facility that serves about 1,500 students, so a pretty large school. And based on JMP criteria, the water service that they have is a basic drinking water service, which is great. It's on site, it's relatively clean, accessible. But from the survey, we had started to find that there were maybe remaining issues and concerns. So this will be reflected a few times. I have a few different plots kind of showing something similar, but among students, about half of them had at least some time or many times in the past week worried about not having enough drinking water. And among staff, that was an even higher percentage that worried about not having enough drinking water. Maybe more shocking or more detrimental to the well-being of students and staff is that about 75% of them said that they couldn't concentrate on class activities because they were thirsty and didn't have a way to get safe water that they felt comfortable drinking despite having this on-premise service. And thinking about what's not captured with these infrastructure measures is also these like the psychosocial burden of water wash issues. And so that's reflected in this question of folks being upset about water problems at the school. We have many more questions about water that were asked, but these were just 3 that I've picked out. And similarly, there was a lot of questions asked about sanitation services. I'll pull out just 3. But in terms of JMP criteria, the school facility had a basic sanitation service. So an improved sanitation service that was on premises, disaggregate gender specific restrooms. And yet, uh, most students reported that they felt unsafe going to the toilet facility. A fewer number of staff said that. There was a different service available for staff. Um, Almost all students said that they thought that the facility provided to them was dirty, a smaller proportion for staff. And again, what I think is an interesting coping strategy or way to deal with this issue is that about 50% of students said that they sometimes eat or drink less food to avoid using the toilet facility at school. So again, you can think about how that would impact uh, their daily living and the type of educational environment and how enriching that can be or not be if somebody is hungry or thirsty because they're trying to forego those things to not have to use the sanitation facility. And finally, I'll call out the hand washing service. So this is one where um, the school did not have a great service available for students. There was no formal hand washing facility. For staff, there was one. So students had to go and basically use the water sources and pumps to get water and wash their hands. Um, so you'll see pretty stark differences here because the infrastructure available to staff and students was very different. But many folks were reporting not having enough water for washing their hands. Um, Even higher percentages reporting not having enough soap for washing their hands, and then overall not being able to wash their hands when they wanted. So this was a reflection of both the limitations in terms of what was available, but also maybe they weren't allowed to leave the classroom, or after dirty activities, there just wasn't a way to clean their hands because it was not feasible to go to the hand washing station. Then there were also a couple questions that don't really have great analogous versions in the JMP criteria, at least not for schools. This is something that's would apply to healthcare facilities in terms of waste management and environmental cleaning. But so for instance, there we had asked students and staff about whether they thought their classrooms were dirty or they thought the school grounds were dirty. And finally, for staff only, we asked a question about whether school activities had been disrupted due to heavy rains. And this was in the past year. And it was shocking to me that near over 70% of people said that many times school activities had been disrupted due to heavy rains. And again, something we aren't typically asking about. So I think the real value add here is that we can start to get at the gender specific differences in experiences of WASH access and get to look at disparities and inequalities among between students and staff members. And then also we can now look into each of those groups. So are there certain student groups that are doing better than others? Um, and within these sites, folks have been making one-page summary reports that have been given back to ministries of education and health and also local leaders to help make sense of what these data mean. So it provides a summary report of both the infrastructure available, but also the experiential data, and gives some practical, easy to implement recommendations. Um, for instance, talking about investing in cleaning and maintaining the student latrines beyond just making sure that the service is available. If they want folks to use that and feel like it's a safe service, potentially consider cleaning that more if possible. And there's been a lot of local interest in this, which has also been really exciting. So our colleagues in country have shared that they want to keep using these experiential measures, and they found that it provided really nice complementary insights to the traditional metrics. So I'll wrap up and just say that there's a lot of opportunities to remain to get engaged with this work and to stay up to date with this project as well. It's ever growing and we are looking for more partners to help implement. So this is a photo of a good number of people involved with the project at the UNC Water and Health meeting this past year, and hopefully I can see you there this year. But as I noted, we're in the implementing phase, so we're looking for more people to implement in different sites. We are starting to have some good representation throughout Africa, but we are sorely missing. I didn't even have to include a whole other chunk of the map because we don't have any sites in South America, Latin America, or North America right now. So we are hoping to get those sites as well and need much more representation from the Middle East and all throughout Asia. And what we are offering as a team is that we have all the protocols necessary for implementing the surveys and the project. So we have the IRB protocols, we have the consent forms, we have the survey forms, and we've also programmed those surveys into Kobo Toolbox and mWater, and are also happy to help work with teams to help translate the tools and implement those into the softwares that they like using or are most comfortable with. So the core project team is myself, Sarah Young at Northwestern, and Christina Barstow and John Brogan at Helvetas. And we're all here and ready to help projects get this off the ground and all stages of the project. So we see it through from inception, planning, seeking ethical approvals, implementation, and then analysis afterwards. So it's a pretty involved partnership, and we want to make this as easy for folks as possible. So if you work in schools or healthcare facilities, you know of funding opportunities or might be a funder yourself, or just want to learn more about the project, please feel free to reach out to me at any time via email. It's there on the screen. And I'll wrap up by just saying once more, this is a reflection of a lot of great work from a lot of folks across many different institutions. Very indebted to them and their hard work. And if you're interested, please, please, please reach out. And otherwise, happy to take questions.
Thanks so much, Josh. Ryan Kronk, who's our moderator for this session, I think has had to step away for a minute. So I'll take over moderation here. Thanks for that great presentation. If feel free, if you have a question, please do put it in the chat. Or if you would like to unmute yourself and ask your question live, please raise your hand and we will call on you. Um, I'm not seeing anything in the chat, so I will kick us off first. And Josh, I'm wondering when these scale or when these scores come back, you
Mhm.
mentioned that sometimes there may be insecurity, for example, because students or patients are not allowed to use a particular facility, but the facility may be there.
Uh-huh.
How would you recommend that people who are collecting this information on insecurity think about improvements based on the scores that they receive?
Yeah, so hopefully these data are actionable. So um, it's a great question. So the finalized tool, as I mentioned, is not, we don't know what the core questions are or what will be the actual ones that we're measuring progress with. That's why we need all these data from all these different sites, and we'll narrow down. Right now, we have quite a number of questions, but we are hoping that once we get data from multiple sites and do the analyses, we can figure out just a core set of maybe a dozen items. This is not meant to be additionally very taxing for people. But once we find those questions, and if, for example, it's some of the ones I presented on, that information would be helpful to know, you can see the contrast of we have this facility on premises, we seem to be providing the service. Why are people reporting that they can't use it, they don't feel safe using it? So I think it is that in and of itself is already actionable. That means that it's probably something related to uh, perceptions of safety, and could also warrant a little bit more of some more focus groups with people. But yeah, I think there's a lot of potential to scale up or rethink projects. So in the household setting, when Helvitas and Charity Water were getting findings back that water issues persisted with cleaning clothes, that has caused them to look back and go, well, why is that? Is that because people are using a different water source for clothing and that wasn't impacted by this project, or is it because the project still isn't delivering enough water for clothing? So I think it helps people pinpoint the issue. So both the infrastructure plus the experiences help you get a much better sense of it. So together, hopefully those are useful. Um, okay, Ram. Yes. Uh, please feel free to email, and I'm happy to share the tools with anybody. The preliminary stuff. Again, as I said, they are not validated. You are welcome to use them. Among those items, the core ones will be in there, but we know that there's currently too many items, and the point of the project is to narrow down and get to just the core set of indicators. Uh,
The chat is pretty quiet right now, but I have another question, Josh. For
okay,
folks who
Darcy?
are asking in the chat if they can access the tools, can you give us an idea if someone reaches out to you and says, "Hey, I'm interested in the tools. I'd like to start this project." What
Yeah.
can they expect as the first step?
Yeah, the first step would be a call so we can get to know each other, um, and to understand what your organization normally does and the scope of work that you're used to doing. So we have worked with people who have never done research projects or have only done internal monitoring and evaluation. And we've also are in partnership with universities. So full range of people. Um, and so it would be setting up that call and just knowing comfort with research activities and uh, trying to figure out the scope of the project, what works well, and how we can navigate. So whether we're plugging into an existing project you're already doing, or if this would be a site that you just have a lot of familiarity with and would like to implement this as a standalone project. Again, we've had both experiences where people are plugging into existing projects or are um, doing a very tailored thing just for this study. So we would review the materials, talk about that, and then also talk about next step with getting ethical approvals for in-country implementation. So we have approvals from Northwestern to just do this across sites, but we also need in-country ethical approval. So that sometimes can be a slower process. That's why, for instance, some of these data have taken a little bit of time to give because getting in-country approval takes a bit of time. Um, but we are really happy to navigate that because we know a lot of NGOs don't typically do that. But yeah, that would be the first step. And then the next couple steps is the timeline. It looks like something like anytime over the next few months. We are looking to implement through early 2026. So we are collecting data all throughout 2025. Typically, once we get the project going, between getting ethical approval, like once people express interest in the project, it can take anywhere from 3 to 6 months before we are actually collecting data and have data in hand because of variations of in-country ethical approvals. But the actual implementation timeline, folks normally can collect the type of data we need and hit those sample sizes I was uh, sharing within 2 or 3 weeks, sometimes a month. Um, yeah. So, and that hopefully that was helpful with the overall timeline. Yeah, okay, great. Yeah, so we're uh, still seeking partnerships. This is going to be ongoing for a good amount of time. To just, I keep comparing it to the household version, but the household project, we did data collection for all of 2017, all of 2018. And so we've collected data 2014, and I suspect doing it all of 2025 as well. And I dropped my email in the chat. So please, please, please feel free to reach out. And like I said, we weren't presenting healthcare facility data, but comparable findings are coming out of that in Uganda of very different experiences between what's being reported in terms of the infrastructure and how people are using it. Hey, Ryan.
Josh, any preliminary high-level findings that you can share, just like initial thoughts or initial trends you're seeing with the healthcare facility data?
Um, Two things. I will say that healthcare facilities are a little bit more tricky than schools in that it's really easy to ask staff about their experiences. It's harder asking patients about their experiences, especially in outpatient facilities. So we're trying to think really critically about people who may not have come into exposure of certain services. So if you're in an outpatient facility and you're there for 45 minutes, maybe you didn't worry about thinking about using the water or um, having to go to the bathroom. So that's something we've been thinking about. But in terms of the actual data in hand and what has been really helpful is seeing the different ways that these issues are impacting the quality of services that people are able to provide. And it's creating real frustration among staff. So when they can't access these critical services, comes as no surprise to probably people on this call that people are nervous that they're providing suboptimal care. Patients feel like they're not getting great care. Um, some of the other findings that have come out are, um, I'm trying to think of the different modules. Uh, yeah, I just feel like a lot of people, yeah, are also find the sanitation facilities are not great and don't want to use them, even when they are seemingly like a good sanitation service, according to the criteria we normally use. I think the water module has been the most interesting because so many people have patients talking about having to bring in water for their own surgeries or for labor and delivery. So um, yeah, I think this is a ripe time to start collecting these type of data too, given that there is such a global push for just we have a lot of gaps in our understanding of wash in these facilities, and we've come a long way in the past decade. And I think as we're scaling this up, this would be the right time to start thinking about integrating these items as well.
Yeah, great, thanks.
Yeah.
Any other final questions? Feel free to raise your hand or unmute. All right. Thanks everyone for joining. Thanks, Josh. Oh, sorry, there is one last question. Specific
Uh,
questions from maternity facilities.
yes, Priya, we do. I would have to pull up the survey exactly. So if you email me, I can send you them. But yes, we have because that is such a key service that's provided at so many of these facilities. We have a couple items for different types of services for different facilities or wards, and one of them is for maternity facilities.
Awesome.
Yeah.
All right. Well, thanks,
Thank you
Josh.
all.
Thanks everyone for joining, and stay tuned for our upcoming webinars, and we will share around any updates that come out from this project through the newsletter. So thanks everyone for joining. Have a great rest of your day.
Take
Bye.
care. Thanks.